So are you okay this way?
Yep, we're just fine. Good
Okay.
evening, everyone. I'm Kim Bischoff, the Executive Director for the NF Network, and we would like to welcome you to our webinar series. Tonight we will be discussing NF1 and School Issues. We have 104 people registered to participate. These webinars have proven to be an excellent way for the network to reach individuals across the country. Tonight we are very fortunate to have with us a very dear friend of mine, Dr. James Tonsgard, who is the Director of the Ambulatory Program for NF at the University of Chicago. The University of Chicago's NF Clinic is one of the largest NF clinics in the country. Dr. Tonsgard has a strong interest in learning and school issues as they relate to NF. The University of Chicago's NF Clinic is part of the NF Clinical Trial Consortium, which is funded through the Congressionally Directed Medical Research Program. We are currently asking our NF families to contact their congressman to request federal funds so that these important programs can continue. To get more information about the network's advocacy program, please go to our website. I have just a few webinar instructions for you. After Dr. Tonsgard's talk tonight, we'll have some limited time for questions and answers. Questions can be asked in two different ways. To write a question to be read out loud, click on the question box, which is located on the lower portion of the webinar control panel. To verbally ask a question, you need to have dialed into the conference call number that was provided. Then you click on the green hand icon in the webinar control panel to indicate that you have a question. When your name is called, your phone will be activated. To remove the webinar control panel from the view of your screen, click the orange rectangular button with the arrow at the top left portion of the control panel. This may be necessary to have complete view of the PowerPoint presentation. And now I would like to introduce to you Dr. James Tonsgard.
Hi, I'm Jim Tonsgard, and we're going to, I guess this is going to be a little bit more formal than I'm used to because I can't see you. I'm going to try and go through the slides, and then hopefully we'll leave enough room for talking. I don't quite know how to interrupt this to answer questions as we go, so I guess my best advice would be to just take notes of things that you want to ask, and then we'll try and cover everything at the end. And as Kim said, I run the NF Clinic at the University of Chicago. We've had an NF clinic for 23, 25 years, something like that. And I'm a pediatric neurologist, but I also see adults. And I am particularly interested in learning problems, and I've been part of the, and actually was the co-chair of the subcommittee for learning problems for the NF consortium that the government has funded. So let's start. Okay, so why should we be interested in school problems at all? Probably the fact that there are 104 of you out there means that we don't need to really justify this, but it is important to point out that about 60% of all kids with NF1 have some kind of learning problem or some kind of difficulty with attention span. So it's in some ways the most major or most common complication of NF1, with the exception, of course, of capillae spots and perhaps Lisch nodules. There are other issues besides basic learning in NF1. Coordination, fine motor coordination, for example, can make it difficult for kids to write or draw sometimes with NF1, and that can impact learning even if their cognitive abilities are perfectly okay. Speech problems are very common in NF1, and that can definitely impact kids in and make it difficult for people to understand what they're saying. Also, some of you may be aware that some kids with NF have trouble socializing with their peers. They don't interact quite as easily, and it's really school is in part socialization and peer relationships and interacting with other kids and working with other kids. So if there's socialization problems, that can impact on learning as well. And my best advice is to begin early and to focus on the development of your very young children. Now, I'm sure all of you know that children learn or develop at different rates. You know, some kids walk before they even start to crawl. Some kids just don't crawl at all. Some kids talk later, but that doesn't mean that they necessarily have problems. And because of this variability, it's a little tough sometimes to be sure whether somebody's quite on target. And I think one of the easiest things to do is to compare your child to other children his or her age. I mean, that has pitfalls. I mean, anybody with multiple children will tell you that, you know, some kids learn or do things faster than other children, but there still is a spectrum, a broad level of expectation of when kids should do things, and that's been incorporated in something called the Denver Developmental Screening Test, and that's something that's easily available to people. You can get copies of it. Typically, pediatricians have a copy in every child's chart, and throughout the time that they're taking care of children, they should be looking at the Denver Developmental Screening Test to check off and make sure that kids are more or less within the expectations of the Denver. For example, it's very variable when most children, when all children walk, but most children really walk by about 16 to 18 months of age at the very latest. And the Denver actually has standards that show you when 80 to 90% of children are expected to do different things, and that can be very helpful. If you have questions about whether you think your child is behind in terms of developmental milestones, or if your pediatrician thinks that your child may be behind, then you should ask to have your child evaluated. And in general, getting young children evaluated is free. It's usually done by the state without cost. And those programs are called either early intervention programs or 0 to 3 programs, and they will do Denver assessments on children, or sometimes Bailey assessments, and determine whether or not your child is within the normal range, or whether the child is significantly behind in certain areas, and then they will actually recommend therapy. And again, that therapy is usually free. In children that are older than 3 years of age, those children are really the responsibility of the local schools. So that once your child turns 3, you can go to your local school and say, you know, that my son is having problems with speech and I need to get him enrolled for speech therapy. And then your local school will go ahead and evaluate him and determine whether or not he does need speech therapy, and then they will provide it until the child is actually ready to go into kindergarten. You don't have to be in kindergarten in order to get the schools to take over and provide some assistance. You know, and as I said, that the key here really is to start looking at learning early. These early intervention programs that they have, the Head Start programs, they really clearly do make a difference. It's been well documented. In addition, speech deserves early attention. I know sometimes I talk to families and they say, well, his speech is improving, and they opt to try to watch speech problems, but I really don't recommend that. Problems with speech really affect how the child interacts with other children and how it interacts with adults. And it affects their perception of themselves. So I like to pounce on problems with speech as early as possible and as aggressively as possible, because in general, most of the speech problems with NF1 really do improve with therapy. Once in a while you see a very severe speech problem that just is very resistant to treatment, but for the most part, they really do respond to treatment. Also, if somebody is having very significant speech problems, it now is clear that some of the kids with NF who have those kinds of speech problems have abnormalities either in the coordination of the muscles of their mouth or in the back of their mouth and throat called the palate, or even in the lower part of the brain. And so it's appropriate if the child's having significant speech difficulties to get the child evaluated. There are people that are called speech pathologists that will do this. In addition, ear, nose, and throat doctors can look at different things in children to make sure that their palate is functioning normally. Sometimes there are little clefts in the palate that aren't obvious that can be found that can contribute to this. So evaluating those kids early is a good thing to do. I also encourage parents to talk to their children as much as possible. Now that may sound dumb, and anybody who knows me knows that I don't talk a lot, and so I'm probably the worst person to give this advice. But there have been studies that show that parents who talk to their children more have more verbal children. That's not to say that they're necessarily smarter, but they're definitely more verbal. Some of that work was done here at the University of Chicago by people I know, and I've seen some of those videos that went into that research. And I've seen videos of parents who would literally stick a 2-year-old on top of the dryer while they're sorting clothes, and the mothers would, with every single piece of clothing, point out what the piece of clothing was, maybe say what its color was, over and over again. Things that I would think, oh, come on. But in reality, it's people that talk more to their children who have more verbal children. Also, you will find in terms of early schooling that some teachers take what I would call a developmental approach to children. That is, that they say that people learn at different rates, that not everybody is ready to learn how to read right away, and not everybody is able to sit down and concentrate right away the way other children are. And that's definitely true, but the downside of that approach, and I can speak for with personal experience on this with our children, is that sometimes the teachers will take this sort of approach and then all of a sudden say, hey, your child's now in 2nd grade, and he's not reading really comfortably, this is a problem. And so it's really better to, I think, push early and watch things early and have some expectations early on, not to be real loose in terms of when children are learning. So I would say that what I try to do is make sure that by the age of 3, all kids know their numbers and their letters, and by the age of 4 that they're recognizing the numbers and letters and what the sounds of those numbers or letters are. And by the time they get into kindergarten, I really want them to be extremely comfortable with the sounds of letters and all their numbers, and even to be recognizing some words. And the reason I push that is that my feeling is that school performance is so heavily based on language that the more verbal children are, the more likely they are to do well. And so I really encourage early learning in kids, whereas in other children I might tend to be a little bit more laid back. Now, what are the things that we might be looking for in children, young children in the first several grades in terms of learning and signs that they might be having difficulties? One thing would be a short attention span, or trouble concentrating, or being very distractible. Now, that's a tough one because there are an awful lot of 5-year-old boys, for example, that have trouble sitting still and are pretty bouncy. But you want to be paying attention to that and getting a sense of whether your child is more distractible or having more problems than the rest of the class. In terms of learning difficulties, you want to be focusing on different areas. You want to be seeing if there are any difficulties with math or math facts or recognizing letters or doing simple operations like simple addition or subtraction. You want to be paying attention to whether people have difficulties with reading or sounding out words. And we'll talk about those specific learning difficulties in a few minutes. And you also want to pay attention to whether the child is understanding what they're reading. Are they comprehending it? Are they retaining it? Then we talked about speech problems, because you want to jump on those if there's an issue there. You want to pay attention to coordination. Fine motor coordination can affect printing and writing, or how you hold a pencil or a crayon, and that's pretty common in NF. And it can be a bit of an issue with young kids. And I always find it a little frustrating because the school, especially in the first, second, third grade, focuses a lot on how well somebody prints, when in real life, nobody worries about what your handwriting is like or what your printing is like later, but it is important early in school, and people do pay attention to it. Very common in NF to have problems with muscle tone, what we call hypotonia or low muscle tone, and that sometimes affects general coordination and running and walking. Then you can also see behavior problems in NF. Hyperactivity and restlessness, impulsiveness, difficulties with organization, mood swings, temper tantrums, even anxiety can all occur fairly commonly in NF. So let's talk a little bit about attention span problems. I think everybody's heard of the attention deficit disorder. You know, what is the attention deficit disorder? It really is due to both structural and functional problems in the brain that affect the connections or the circuits between different areas of brain. And there's some very interesting research now that's going on in terms of that, and also in terms of NF that actually shows some of these circuits. And what that means is that if there are problems with these connections between one area of the brain and another, then processing information is slower or less efficient. And if that processing is slower, then kids have a harder time continuing to pay attention, what we call vigilance. Also, if these circuits are slower, they're prone to being distracted. And when kids become distracted, they can skip over questions and answer things incorrectly when really all they did was simply skip over something. And also, if these connections are slower, then kids have trouble shifting their attention from one topic to the next as fast as other people do. And that can make things more difficult. So short attention span can affect reading, and it can affect listening and comprehension. And because it affects those areas, it can make a difference in how information is taken in and how actually the information is saved within the brain. It can make the whole process slow enough that some information just doesn't get saved because the kids get too frustrated. It is not unusual at all for kids to have behavioral issues in addition to the distractibility or short attention span. They can be very impulsive, very restless. Another feature which you may be hearing more about in the last few years in attention deficit is what's called executive function. Now, what is executive function? Executive function are primarily functions that occur in the front part of the brain, and they affect the flexibility with which you're thinking about things. Can you shift frames and look at something in a different way? It affects how rapidly you process information. It also affects problem solving and making choices, so that it's not unusual at all for kids with executive function problems to not be able to make choices, or finally to make a choice and it be the wrong choice. And that can be an executive function problem. They can also have problems initiating learning or initiating actions. That is, choosing to do something. I see quite frequently that parents or teachers will complain that Johnny is lazy or he doesn't want to do the work, when in point of fact, I think oftentimes it's an issue of initiating the work, starting it, that they have trouble getting going. Or given a couple choices of what to do, they make the wrong choice, not that they're lazy. Also, executive function affects organization, so that you frequently see kids are terribly disorganized and have trouble sorting through things and keeping assignments. And that impacts on how they retain information. In addition, executive function controls impulses And kids with executive function problems tend to be impulsive, a little bouncy, if you will. It is important to recognize that attention deficit can continue into adult years, and that can be a problem for adults at times. Now, I'm sure you all know that medicines are used to help with attention span, and there are quite a variety of medicines now that are available. Most of the medicines are some form of Ritalin or methylphenidate, but there are other medicines as well, and they can be extremely effective, and in particular in NF, they can be very effective. There are, in addition, behavioral approaches that can be used for people with attention deficit. There are techniques of redirection and different behavioral approaches that behavioral therapists can teach teachers to use. And sometimes that can be successful, although more often than not, medicine is sometimes needed. Now, learning in general. It is important to realize that kids with NF1 can have perfectly normal or even above normal intelligence. But in general, when you take a large group of children with NF and you measure their IQ scores, those IQ scores tend to be in the normal to low normal range. And there have been studies that suggest that if you take sibling pairs where one child has NF and the other child doesn't, that more commonly than not, the child with NF is going to have a slightly lower IQ score than their unaffected sibling. That's not to say that they're not within the normal range, but there can be a difference. 1/3 of all kids with NF don't have learning problems, and it's important to recognize that too. So you don't have to be assuming that they're going to be learning problems. Mental retardation does happen in NF, and it probably happens a little bit more commonly than the general population. It's not a terribly common problem in NF, but it definitely occurs. Autism is also something that we see in NF, not very commonly, fairly uncommonly really, but enough so that there was a debate a few years ago in the NF community as to whether autism was more common in NF1 than in the regular population, and I think it's fairly clear that autism is a little bit more common, but not hugely. I think the most common scenario that we see is kids with NF1 who have perfectly normal IQ scores, but they have specific areas of weakness in their learning. And we call those learning disabilities. That is that their performance in certain areas is lower than we would have expected based on their overall IQ. And you can think of it just as specific areas of weakness. I mean, we all learn differently, and we all have weaknesses in the way we learn. But for some people with learning disabilities, those weaknesses can be really prominent and make things more difficult. And it's very helpful to understand in children that are struggling with learning where their strengths and where their weaknesses are. Because if they can be taught towards their strengths and use those strengths to overcome areas of weakness, that's important. And if there are specific areas of weakness, there can be strategies that can be used to help children with learning. And these are really three of the specific learning difficulties that occur in NF1. There is what we call a language disorder. And in these children, what you see is difficulty expressing themselves. This can be both written and verbal. So that you can ask a child to write a sentence about something or write a paragraph about a particular topic, or to talk to you about something, and what you get back is the most simplest of sentences. They have trouble sort of explaining their ideas. And oftentimes what's needed is a coach or an intermediary to help draw those ideas out, draw out the expression, and get kids to be able to express themselves better. Also, kids with language disorders can have difficulty listening and understanding what they're hearing, or difficulty remembering things that are spoken, what we call auditory processing problems. And the auditory and processing problems can be separate from problems with expressive language, or they can be part of that. It's not unusual as well for kids who have language disorders to have problems with attention span. Another specific learning disability is what's called a reading disorder. And that's particularly common in NF. And it typically happens in kids who have language disorders, but it, and it's really kind of, in many ways, just a part of language disorders. What you see is that children have trouble decoding words. They have trouble sounding things out. And if it's very severe, we call that dyslexia. And it can affect the way kids learn to read. And kids who have this particular problem have to be taught in a somewhat different manner than other children. And I've got a slide here that will show that in a minute. But for example, kids who have trouble sounding out words, it's not terribly helpful for them to be taught reading using what's called a phonetic approach. It makes actually more sense to teach those children by helping them to memorize things. And memorizing is a perfectly valid way of learning how to read. Then even kids who are able to read sometimes have difficulty understanding what the words mean or what the sentences mean, trouble with comprehension. Then a somewhat separate area is what we call mathematics disorder, and sometimes you'll this is part of what we call visuospatial or visual perceptual problems. And here kids have trouble with math concepts. They have trouble with writing things down, have trouble with keeping columns of numbers in an organized kind of way. And frequently, these kids also have problems with attention span. Now, here is an example of what I was talking about in terms of dyslexia or reading problems. In kids who have decoding or language problems, if they see the letter SAW, S-A-W, they may actually get the letters reversed, and they may say that the word is was instead of saw. And the reason they do that is that they're perceiving those letters to be mixed up. You can also, in some people, have instances where the letters or the words seem to get blurred and they can't quite see them correctly. Or there are examples where kids see a sentence and they get the words in the sentence completely out of order. And that, of course, can make things very difficult. Now, if you're teaching somebody how to read, the standard way of doing that is what we call a phonetic approach. So, for example, if you're trying to get somebody to read the word bus, then the phonetic approach is that you learn the sound for the word b, bu. You learn the different sounds for the word, for the letter u, and then you learn the sounds for the letter s. And you put that together, s, and you can get kids to learn to read and to learn to recognize that that's the letter. That's the word bus. On the other hand, there are some words in which a phonetic approach does no good whatsoever. So, for example, the word phonetic. You know, when you're learning the alphabet, the P sounds like P, and the H sounds like H. But when it's put together, it actually sounds like F. So that can be very, very confusing for people who have language disorders. And there, memorizing is the way to go. Now, this is an example of visuospatial problems. And I think a lot of people have trouble understanding what visuospatial problems are. And this is something that I pulled off the internet. It's a picture of, or two pictures that a girl drew, and when she was asked to draw a picture of a bicycle. And the top one shows her attempt when she was about 9 years of age. And I think most people would be very hard-pressed to recognize that this was a bicycle. And a 9 going on 10-year-olds really should be able to draw a bicycle. I mean, here are the handlebars up here. Here's the a couple of spokes, but they're sort of completely separated from everything. Here are the pedals, which are way out of proportion to the spokes and the wheels. Really hard to figure out what that is. And that's fairly typical of kids who have visual spatial problems. And it can be worse if kids are asked to copy things. So, for example, this kid could have been given a picture of a bicycle and asked to reproduce it, and this could have been the result. Then when she got to be a bit older, now this is much more recognizable as a bicycle, but remember, this girl's almost 13, and this is still a pretty primitive representation of a bicycle. So this shows you what kind of visual spatial problems you can get, and there are specific tests that we use to try and sort through this and demonstrate whether people have visual spatial problems. Okay, then behavioral issues. And we don't talk very much about this, but I think it is worth talking about. There are behavior problems in NF1, and that's not to say that the kids are bad, but it's something that we shouldn't ignore. Hyperactivity is awfully common. That's definitely an issue. Also, just the opposite. Some kids with NF1 have a lot of trouble interacting with their peers, and they're very shy and awkward, and they tend to stay by themselves in some respects. Or because they're not interacting with their peers as much, they actually seem a little bit much more immature. there have been studies that show that some kids with NF have relatively poor adaptive skills, so that they have trouble taking charge and leading. And there can be other behavioral issues as well. So I think it's important to identify behavioral issues and to ask your doctor about that, because there are behavioral modification techniques that can be used to help with that. Okay, so let's get a little bit more practical and away from the abstract. What do we? The first step, I think, is to always be regularly asking your teacher how your child's doing in school. Don't wait for the parent-teacher conferences. See the teacher regularly and just see how things are going. Is the child working at the level of the rest of the group? You know, if he or she is in right in the middle of the group in terms of abilities and performance, great. But if the teacher says that, well, he's okay, but he is lower at a lower level than some of the other kids, then that tells you right away that you want to get this kid evaluated. And you should be aggressive about this. If the teacher indicates that there may be difficulties, you know, sometimes what the teachers say, oh, Johnny is a great kid. We love him very much. He is struggling in certain areas, but he'll come along. Well, I think that that's an indication to want to get Johnny evaluated. That's not to say that one necessarily has to do that much, but why not evaluate him and see where he's really functioning? Are there issues? You want to be more aggressive because of the high incidence of problems in NF. And evaluation in school is what's called an individual education plan. It's a formal process in which the children go through different kinds of testing by a psychologist, and then the teacher and the school psychologist and the therapists and social workers sit down and they make recommendations about what they think is going on. The IEP usually involves a formal IQ testing as well as what we call achievement tests, so that it tells you where the child is in terms of basic math and reading and spelling, but it also, with the IQ testing, gives you an idea of what the child's abilities are. An IEP is free, doesn't cost you anything, and even for children who are in private schools, the public schools are required to perform IEPs on kids in private schools. They may be slow in doing it, but it can be done. You know, there is the issue of whether you want to inform your school or your teacher that your child has NF. Parents feel differently about that, and I think one has to do this on a case-by-case basis. It does sometimes help to point out that if Johnny's having some difficulties and he has NF, the likelihood is that he does have significant learning problems, but people feel differently about whether they want the school to know that information. So how do you request an IEP? Usually there is a specific form in the principal's office that you have to sign requesting the IEP. You date it, and you give it to the principal, and you ask them to consider doing an IEP. I recommend that you ask to have a copy of that so that you can keep it. Because every once in a while we run into instances where the school denies that you ever made the request, and then you have to start all over again. It takes a while for this process. The school has 60 working days to respond to your request. And unfortunately, they do have the right to refuse to do an IP. They can say that we've looked at Johnny in the classroom and we think that he's functioning just fine and we're not going to do it. And then that can be a problem. You can go to your doctor and say, what should I do? And that may be the time to play the card and say, well, Johnny has NF, and we know that there's a high incidence of learning problems, and get your doctor to write a note saying that he really feels that they need to do an IEP. There is now a tendency in the public schools to do what they call some sort of intervention, where they do simple measures to see if they can help learning without doing a formal IEP. Unfortunately, this is kind of a waiting technique. I don't think it's usually very effective, but sometimes we have to put up with that. It is helpful if you can convince a teacher or a therapist that there are issues, because then the teacher or the therapist can back you up and say, look, if Johnny's really having significant difficulties, he needs to have the IEP done. When the IEP is done, they usually have a conference with you, and they go over all the findings, and they put together a document that's several pages long that they give you a copy of. And I strongly recommend that you then take that to your doctor and show it to your doctor so that he can take a look at that, because the quality of evaluations varies a lot. Some schools do a very good job, other schools do kind of a crummy job. And hopefully your doctor will have some familiarity with IEPs and intellectual testing and be able to say, you know, I think they did a good job, or no, I don't think they did a good job. Or you can ask to see somebody who can look at the IEP and give an opinion. The IEP involves neuropsychological testing, but you can also get neuropsychological testing done privately. And what that does is it looks at how your child processes information, how he sees or hears or retains information, how he organizes information or facts, how he decides or chooses what to do with the information, whether or not he's distractible. It measures his basic reading level, math level and math concepts, figures out how he reads and how he learns new words. It basically assesses your child's potential to learn in addition to what the child already knows. And good neuropsychological testing will make very specific recommendations on how to improve learning. It will suggest different tutors, perhaps, or coaches. It can suggest speech therapy, occupational therapy, work on social skills. There are a variety of things that they can make recommendations for. Now, sometimes you will run into what's called a 504 plan, and you need to know about that. Basically, schools are required to provide resources for children that are appropriate for that individual child. Not what the school has available, but what's appropriate for your child. They get around that somewhat by what they call the 504 plan. And it was really designed for children with physical disabilities. So kids, for example, who have arthritis or problems with vision or asthma or hearing problems, who may not have much in the way of true learning difficulties, but have physical disabilities that make it make school harder, they put in what's called a 504 plan, where they simply provide supplements to help children with school. So what they do is they don't evaluate children. They just make different accommodations for children. A 504 plan is better than nothing, but you want to try and avoid it if you can, because an IEP is much better. So I'm going to stop in just a second. I've probably taken too long, but I do want to point out that that there are lots of studies that are going on right now to help us understand learning and to help with learning. And I encourage you to be part of those. We're doing a study with Bonnie Tasman-Klein at the University of Wisconsin, trying to identify risk factors for very young children with learning problems. Catherine North in Australia for several years has been looking at learning and reading, and Laurie Cutting at Vanderbilt University has a funded grant to look at learning and interventions for learning. Then Maria Acosta and Karen Walsh at National DC Children's Hospital are looking at a computerized cognitive training program to help learning, and you'll probably be hearing more about that soon. Maria is also looking at functional MRI scans to understand the learning circuitry in kids with NF1 and see if there are consistent patterns and ways of improving that. Nikki Ulrich at Boston Children's Hospital is looking at visuospatial problems in adolescents with NF1 and has been doing some very nice work in that. And then the NF Consortium, of course, is looking at whether the cholesterol-lowering drug lovastatin can improve learning in NF1. And we don't really have time to talk about that now, but that's an important trial that's going on. There are specific resources that you need to be aware of. There is something called the Learning Disabilities Association, and they really provide excellent information on learning disabilities and how to intervene and what resources are available. There's also an organization that's been around for a long time called CHAD, Children and Adults with Attention Deficit Disorder. They really provide wonderful support and information, and they can also provide sometimes discounts on medicine. There's also an organization called the Attention Deficit Association, which also has good information on the internet. Your local NF clinic should be very knowledgeable about learning problems as well and provide resources for you. And you should be able to get good neuropsychological testing or information from pediatric neuropsychologists, and they're usually at all of the major medical centers. And really, I think with that, we'll stop. I haven't left much time for questions, but hopefully we can get some through.
Thank you, Dr. Tonsgard. And yes, there are a couple of questions here. The first one that I'd like to read is, how are executive function issues best managed, and do attention deficit medications help with the executive function?
Yes. That hasn't been quite as well studied as it needs to be. The medicines for attention deficit are best for attention span, but they definitely can improve executive function problems, particularly impulsiveness. They're not so good with organization, and they're not necessarily particularly good with decision-making and choices. Those are things that require more individual sort of behavioral therapy and counseling.
Okay, thank you. I'm going to get on to the next question because we have quite a few here. This one I'm going to try to summarize just a little bit. There's a youngster who's 10 years old. He's been taking Concerta. They've just changed him to, and I'm not positive I'm saying this right, Focalin, F-O-C-A-L-I-N.
Focalin. Mm-hmm.
All right, and they're just saying the youngster doesn't seem to be doing as well, now is having some sleep problems. Can you give us some advice about Concerta versus Visuospatial?
Yeah. There are quite a variety of different medicines for attention deficit. Most of them are variations on Ritalin or methylphenidate, but surprisingly, a given child's response to these medicines differs tremendously. So the fact that a child did decently on Concerta doesn't necessarily mean that it will do well on Focalin or vice versa. My preference is for the most long-acting of the preparations, because one of the things that you see with the Ritalin agents is that sometimes they're very helpful for the first hour or 2 hours, or if you're lucky, 3 hours. But after that, the medicine wears off, and sometimes what you see is what I would call a rebound effect, where the child seemed to be under control and doing pretty well, and then bam, as soon as the medicine wears off, they're almost worse than they were. And you seem to have less problems with that rebound effect with the very long-acting preparations. And those two are Daytrana, which is a patch that you can wear, or Vyvanse, which is a combination of Adderall and methylphenidate. Those two preparations are very long-acting. Concerta is intermediate acting. It commonly lasts for maybe 5 hours. Focalin tends to be shorter acting and doesn't act for as long. So in the old days, what we used to do is give people small doses of Ritalin a few times a day. So give somebody a medicine at 8 o'clock and again at noon and again perhaps at 4 o'clock if they have to get home and do homework. It sort of varies. That's kind of frustrating, but that approach does sometimes work. One of the side effects of the Ritalin-like agents is that it sometimes interferes with sleep. I find that less true with the very long-acting preparations, but it can happen with all of them. And sometimes we have to give medicine specifically to help kids sleep at night. And there's nothing wrong with that. There are some very simple medicines that are very benign that we can use to help with sleep. Because what happens sometimes, as I say, kids are seem to be controlled in terms of their impulsiveness or their hyperactiveness when they're on the medicine, but as soon as the medicine wears off, they're wired, and sometimes it's hard to get them to settle down for sleep.
And here's one that I'd really like you to hear. What if the school is upset with your child being behind in math and reading, but are not working or willing to use things to help them? They're upset with her writing and upsetting her with trying to correct. What can I do?
Well, there I think your doctor has to intervene, and probably what you have to do then is get an outside neuropsychological testing evaluation, and then get somebody to advocate for your child. I find it terribly frustrating that schools spend so much time concentrating on how well you can print when we all know that we're using the computers and typing away, and how well we can print makes absolutely no difference in our adult functioning. But schools can get really distracted. So you're better off trying to get an advocate. See if your doctor is willing to step in and talk to the school or write a letter or get private neuropsychological testing, and oftentimes really good neuropsychological testing, the people will actually be willing to talk to the schools.
And I think this one leads in, it's a good one to lead off of that one. How often should a teen 15 years old with expressive NF have a neuropsych evaluation? Our new psychiatrist is also professor in genetics and is suggesting he have a neuropsych done every year.
Oh, no. No, I don't think you have to have a neuropsych evaluation done every year. I think most neuropsychologists, even the aggressive ones, would think that every 2 to maybe every 3 years would be appropriate. But every year is a little excessive.
Okay, and I'm going to try to keep us a little bit closer to our time. So there's 2 questions that have come up here quite a bit. And one of them is asking about an update on the lovastatin trial. And what I'd like to do is, I know that that's a whole topic in of itself, and maybe ask that we do a webinar on that sometime in the future where we could address that and get some updates going on there.
But yes, but let's just say that we desperately need additional people to participate in that study. It's an important study, and we don't have any information on it, on the results yet. But we're going to need more patients in order to be able to really complete the study, and we're working hard at that. But participating would be really helpful.
Oh, very good point. And then the last one that we've had is that many people are asking if the presentation is going to be available after tonight. And I'd like to say that yes, it is, that the presentation has been recorded tonight, and it'll be available on our website in just a couple of days. So if you know of an educator or a healthcare professional or somebody else who wasn't able to attend tonight, that you'll be able to direct them to the NF Network site to be able to view it. And also, you'll be receiving a follow-up email from tonight, and Dr. Tonsgard has written a paper about NF and learning disabilities, and there'll be directions in that follow-up email where you can find it on our website.
And I am going to make some changes in it, too, so that there'll be an updated version that will be available within a few days. Perfectly willing to continue, Kim, if you want to. Okay.
Oh, all right. Well, then we can take a couple more questions.
That's fine.
Okay. All right. Well, here's one. This one says, do you ever see issues of OCD in executive function?
Yes and no. You can see anxiety in some kids with executive function problems. And sometimes medications for attention deficit make anxiety worse and can make obsessive features worse. I wouldn't say that I've ever seen true OCD, but certainly anxiety, and sometimes some repetitive or a little bit autistic-like sort of behaviors you sometimes see.
Okay, well then here's another question. If a parent is not a fan of medication, will the alternative choices that work for ADD and ADHD work for children who have NF1?
Yes. There are some interesting studies that are starting now or going to start in which different kinds of computerized programs are being used to help children learn. And those could be beneficial to kids in the absence of medicine. Behavioral modification techniques sometimes really do work. But while I understand people's fear of medication, if you're dealing with somebody who's knowledgeable about the different medicines and sensitive to the potential side effects and is really sort of on top of the situation, I think that medicine can be terribly helpful for some kids with NF. I would urge people to keep a little bit of an open mind.
Okay, and then here's another question. What reading programs are most beneficial to use with students who have NF?
Oh, you know, I forgot to pull that information, but there are some specific reading programs that have been recommended, particularly for non-phonetic approaches to reading, and I'll try and find that information for you. But there are, if your child's struggling with reading, you may want to talk to the school psychologist and say, you know, there is a common problem in many kids with NF that they have a kind of dyslexia, not true dyslexia, but significant verbal disabilities that make phonetic learning difficult. Then hopefully the school psychologist will be able to advise the teacher about specific programs that can be used.
Okay, here's another question about the lovastatin study. Can your child be in lovastatin study if they have epilepsy and are on epileptic meds?
No, they can't, unfortunately. That's not allowed.
Our 15-year-old son had a school speech evaluation because we, his parents and others that have been familiar with him since infancy, were concerned that his speech articulation was regressing. School speech eval suggested outside eval and went to Children's Boston, and they suggested, oh, and that's the end. The rest of the typing didn't come through. Let's see. Let me scroll down to see if it picks up later on. Yep, here. And let's see. They went to Children's Boston and suggested that it was attention related. He is now drooling more often. Should we be worried?
Well, the woman who runs the program at the NF clinic at Boston Children's is first rate, so I would just talk to her about that and just see. It's a little unusual. I'm not quite sure what to say about that, but I'm quite sure she would be interested in that information.
And then this is a question that says, could you repeat the names of the long-lasting ADHD drugs?
Sure. Daytrana, D-A-Y-T-R-A-N-A, that's the patch. It comes in different sizes. You put it on the skin, really on the buttock, under your underwear. It's very small, like a little circular Band-Aid, and you take it off at the end of the day. And then there's Vyvanse, V-Y-D-A-N-S-E, and that's a long-acting preparation as well. It's a combination of Adderall and Ritalin, and that's a pill. Those are the two longest-acting preparations.
Okay. Do you have any thoughts about motivational deficits in ADHD and how to resolve them if present?
Well, that is part of the executive function problems, you know, and I don't know whether you would, in fairness, call it motivational or trouble initiating. You know, again, it gets into this concept that some people have that Johnny's lazy, when in fact it's an issue with getting going or figuring out how to get going or what to tackle first. And their coaches learning disability coaches that can be found. And the schools, to some extent, have some of that, in that it's very common in high school, for example, for the schools to have resource people that check to make sure that the child has his or her assignments, that they have the books that they need to take home, and hopefully that person could even be suggesting, you know, what to tackle first or something like that. But it is hard. And the other thing that we see sometimes in this so-called motivational issue is that if kids have difficulty concentrating, or they have difficulty understanding things or getting things completed, they sometimes have a sense of, oh, you know, what's the point? Somewhat defeatist, and it's really important to work with that. And that's complicated. It has to be a process that involves the teacher, it involves the student, and probably a third party, some sort of coach or psychologist who's going to identify those issues.
Somebody's asking just for a clarification on what do you mean by coaches?
Well, there are people that are experienced in learning disabilities who advertise themselves as either tutors or assistants to help with learning, and specifically for kids with learning disabilities. I mean, you're going to see that more in the urban areas, but there definitely are those kinds of people available.
Okay, and then this one will be our last question tonight. If a child is learning appropriately at the kindergarten age and all seems okay, are there mile markers when you may see a change, or does a child tend to stay consistent in their learning capabilities?
No, there isn't a sort of consistency, or rather, it's important to recognize that learning disabilities can become apparent at different ages. Some of the most obvious or severe learning problems are going to be apparent in kids in kindergarten or first grade, but some kinds of learning issues really don't become apparent until later on. For example, the pace of school significantly picks up in third or fourth grade, and also then the subjects and type of material that kids are given shifts at different ages. So, for example, some kids who have visuospatial problems do very well in the first several grades, but then when they hit high school and all of a sudden are faced with algebra or geometry, are completely lost. And I've had kids who I thought were just absolute stars in the primary grades, and then all of a sudden they hit algebra and they're getting poor grades when the rest of it they're doing, you know, A and B work. And so we've gone on and tested some of those kids, and lo and behold, they have visuospatial learning problems, but they weren't really apparent because those kinds of problems really weren't emphasized until high school, for example. And the other thing that you have to be aware of, too, is that, for example, there are a fair number of kids with NF who have the attention deficit disorder without hyperactivity. Kids with the attention deficit disorder with hyperactivity are usually pretty obvious at 5, 6, 7 years of age. But kids with attention deficit without hyperactivity, they can sort of go under the radar and not be apparent right away. And so it may be that people don't pick up on attention span difficulties until kids are, in 3rd or 4th grade or something like that. And then they say, hey, she's having difficulties concentrating, and we didn't realize that.
And I know I said that was the last question, but I think this one's quick. I just want to get one more in here if we can.
Fine, I have no problems with it.
When getting an outside evaluation for ADHD, what is the difference between a psychological evaluation and a neuropsychological evaluation?
There probably isn't a difference. The people that are probably the best are people that have done specific neuropsychological training. That is, there is a training program not just for psychologists who also do testing, but for neuropsychologists, so that there's a little bit more emphasis on learning about different diseases and how those might affect learning, and a little bit more clinical aspect to it. For example, I have a neuropsychology graduate student that's spending 6 months with me in the clinic, and she's getting to see all sorts of different medical problems and how those might affect learning.
Okay, well, I'd just like to say that if anybody is interested in getting more information about the clinical trials for learning disability, the lovastatin that Dr. Tonsgard mentioned, you can call me at the office to find out where you can participate in that, of course at the University of Chicago, but Dr. Tonsgard, are all the centers doing that or just some of the centers?
All the centers are doing it, so that would be, there's a center in Boston, there's a center in Philadelphia, there's a center in Washington, D.C., at Cincinnati, in Chicago, St. Louis, Utah, and Texas has been added specifically for the lovastatin trial. Los Angeles Children's Hospital has been added. I think those are the sites that I can think of right now.
And if anybody would like me to help them find those places and give contact information for them, you can call me here at the office in the morning. It's 630-510-1115. And then I would just like to say good night to everybody and thank you to Dr. Tonsgard for this very informative presentation this evening, and to remind everybody that in a couple of days we will have it posted on the website so you can share it with others. Thank you.